Truth be told, as a primary care PA, you're not really, especially in the military, you're not going to be managing, I don't know, you're not going to be managing pregnant patients. Unless you happen to be on a C-17 on the way back from Iraq and there's a pregnant patient on that C-17 with you, and she has a baby, then you're going to be managing them. So you gotta know basics. We're not obstetricians, we're not gynecologists, so I'm not teaching you to that level. But even the pants, the amount of OBGYN on the pants, even though it's still only 7% total, the amount of OB on the pants has significantly increased in the last couple of years. Because the pants isn't written just for military folks, right? Non-military people do take the pants exam. So we're going to talk about really kind of an overview of prenatal stuff, and then into pregnancy, and then we'll end with pregnancy complications. Those are things that I feel like I felt like I wish I would have known as a primary care PA without going to too in-depth. So if there's other in-depth stuff you want to know, you can talk to me offline about it. We can see if I can maybe answer those questions. But these are the things I think as a primary care PA you probably need to know. So I like this. The only thing I want negative in my life is a pregnancy test. Most people don't feel that way when they first get pregnant. They're like, I'm so excited, it's pregnancy, it's great. And then the nausea and vomiting start. And then the baby gets bigger. And then we got the swelling. So overall, by the end of the pregnancy, they're probably still super happy they got pregnant and made it through the pregnancy. But there are some times they look back and say, oh, that was a little bit rough. And each pregnancy is different. And that's what we have to remind ourselves. Even as parents, you have to think about the kids that you've had and how different one kid can be from another. Each pregnancy is different as well. Back before we had ultrasounds and all these fancy equipment, and you've talked to your grandparents probably, they can tell you, oh, by the way you're carrying that baby, that must be a boy. By the way that you're doing this, that must be a girl. And so now we're able to use ultrasound and to help kind of figure that kind of stuff out. But in general, pregnancy is probably a fun time of life overall, but there are going to be some complications that we have to talk about. All right, so we're on TLOs and then our ELOs. First check on learning, 32-year-old female comes in, she's got a growth-restricted imprint that she gave birth to as hydrocephaly, monocular vision loss, and intracranial ring calcifications on imaging. Based on that, what does she got? Toxo. Intracranial calcifications, toxoplasmosis. Okay? In addition to that, she has this garden that she home grows all her food and only eats fresh meat from the deli. Ooh, man, that's not good. All right, so this patient has toxo. Now you got a 29-year-old G1P1, delivered an infant at 30 weeks. 30 weeks. It's a little bit early. 4 weeks after delivery, on the newborn hearing screening exam, it's identified a hearing loss in both ears. Based on that, what do you got? CMV. So as part of the game, we had all this other extraneous stuff in there, but make sure you understand and pick out those key points. So sensory nerve hearing loss, number one cause is CMV. All right, terminology associated with pregnancy and surrounding pregnancy, gravida. Gravida is the number of times a woman has been pregnant, regardless of the pregnancy outcome. Okay, I've had 3 pregnancies, but I had 2 miscarriages. I still have had 3 pregnancies. Okay? And it doesn't matter how many babies mom is carrying, that's still 1 pregnancy. Okay, so if we have a G1, and then we go all the way down, but we have 6 living kids, well, she had 6 babies, but she only had 1 pregnancy. Okay, so if she had twins, that's going to be 1 pregnancy, and living will be 2. Nulla gravida, no prior pregnancies. Okay, prima gravida, this is currently the first pregnancy, and then multi-gravida, 2 or more pregnancies. We had 1 before, and now I'm currently pregnant. That's 2 or more pregnancies. Parity is the number of births after 20 weeks. Number of births after 20 weeks. okay? And again, it doesn't matter how many children they gave birth to at that time, 2, 3, 4, that's still considered one episode of giving birth. Okay, nullipara, no prior births, no births prior to 20 weeks. Primipara, one birth, that's after 20 weeks. And then multipara, 2 or more births after 20 weeks. Grand multipara, 5 or more births after 20 weeks. Okay. Trimesters depend on what you read, will depend on what weeks range from one trimester to another. But the easiest way to do it is just kind of split them up into 14 weeks. That's what American College of Gynecology primarily does, is 14 weeks. So conception to the first 14 weeks is first trimester, second trimester is 15 to 28, and then third trimester 29 up to all the way up to 42 weeks. Again, we split those up into 14 weeks. Estimated gestational age is how far along is this pregnancy, and it's typically documented in weeks plus days. And there's 2 ways we can do that. We can do, let's say they're 36 weeks and they're 3 days, 36 plus 3 over 7, or you can just do 36 plus 3. And these are 36 weeks and 3 days. Okay, other terminology, embryo, that's fertilization through the end of week 10, so that'd be 10 weeks and 6/7, so just before 11 weeks. Fetus is 11 weeks through birth. Okay, abortus is a pregnancy loss that occurs before 20 weeks gestation. And then preterm delivery, born before 37 weeks. Okay, there are different components of that preterm delivery based on weeks. You don't need to know that. Just know preterm before 37 weeks. Term, infant delivery at 37 weeks and then 41 6/7. And then post-term is 42 weeks and above. The youngest baby to be delivered and to survive is this young man. His name is Cy Mason. And 21 weeks and 1 day. Okay? He was born in 2020, so he's just shy of 5 years. He was born July 5th. He was 132 days premature. He did have a twin that died shortly after birth. And this kiddo spent 275 days in the NICU. Okay? His mom says that he is otherwise doing well, had slight developmental delay. The last time she reported was when he was 4, but otherwise is off his oxygen, walks, talks, and does pretty well. And Dr. Klein and I were talking. She said, it's so amazing that this kid born at 21 weeks is doing okay when we have kids born, sometimes 30 weeks or 32 weeks that don't do well. So it all just depends, right? This little tiny baby. My daughter, when she was born at 4 pounds, and she came home at 4 pounds. So she was really tiny as well. We had clothes for her that really did not fit at all. Right. So preconception counseling. We've talked about preconception counseling a lot from the very beginning. And this is us talking to our patients when they come in for just routine evaluation and talk to them about their plan for pregnancy, if there's a plan for pregnancy. Because prenatal care needs to occur before pregnancy. Okay? Oftentimes, by the time they have that first visit, which is about 10 to 12 weeks, things have already occurred. Okay? Neuro 2 closes at 28 to 32 days gestation. Okay? For 10 weeks before we're talking to our patients about supplementation, that's too late. Okay? Organogenesis, placental development starts within 1 week of pregnancy. So we want to talk to our patients about what supplements they need and how they need to adjust their diet before they get pregnant. And the real issue is there's no checklist to do that. Everybody agrees that preconception counseling is important, but we like to know how to do it, right? We like to have kind of especially in the military mindset, we like to have a checklist on how we're supposed to do this, what we're supposed to talk to our patients about. So we have this big lack of consensus on what we should talk about and what we should implement in this preconception counseling. But if we wait until after the patient is pregnant, we have a lot higher risk of low birth weight for our fetus, okay? Higher risk of preeclampsia, higher risk of intrauterine growth restriction as well. So those are all complications that are typically associated with poor nutrition or even poor management of underlying chronic medical condition. Okay? Remember that maternal health, of course, is going to impact fetal health. So we've got to talk to our moms or soon-to-be moms about how they're going to manage their pregnancy from the beginning and even before pregnancy. Folic acid supplementation should begin at least 1 month, but ideally 3 months prior to pregnancy. Should continue through the 12th week of pregnancy. If mom has underlying hypertension, diabetes, thyroid disorders, we've got to look at their medications and make sure those medications are safe in pregnancy, and we've got to optimize these underlying comorbidities. We got to again talk about not just medications, but also substances that they may be using. If they have been pregnant before, how did their pregnancy go? How did they ultimately deliver the baby? Was there any complications in their pregnancy? What about any sort of family history? Okay, is there a family history of some sort of genetic disorder that these patients need to be tested for early on? Okay, any sort of lifestyle modifications. If someone comes in, one of the main things people really don't want to talk about is weight. And it's hard because we don't want to be aggressive towards our patients on weight loss or weight gain. Okay? But we need to have a good conversation with these patients about their weight and their expected weight gain during the pregnancy. We've got to make sure that immunizations are up to date before pregnancy, and then we'll talk to them again about genetic screening if that is needed based on their personal or family history. All women that are thinking about getting pregnant are typically offered this preconception carrier screening. It can be done at any point, but ideally this specific genetic screening is performed before pregnancy, but if that doesn't happen, it can be performed in that first trimester as well. For preconception carrier screening, it's kind of limited in the screening that it do. It's really cystic fibrosis. They look for hemoglobinopathies like sickle cell, Tay-Sachs, and then they'll look for Fragile X. And immunizations, hepatitis, yes?
Question on that preconception carrier screening. Is that something that we as primary care providers can order out, or how does that work?
You can order them. I remember for primary care, I say you're out there. Since I've been primary care, but I remember ordering this when patients came in and they were concerned because they wanted to get pregnant, and I was able to order it. Immunizations, hepatitis B, maybe have a pneumococcal, MMR. Remember, MMR cannot be given, varicella. Those things should be done prior to pregnancy. And then influenza can be given at any point in pregnancy. Hepatitis B can be given at any point in pregnancy. And then really important that you need to underline tetanus, 27 to 36 weeks. Why do we give tetanus in mom, even if she's had it? What if she was pregnant 2 years ago? Do we give it tetanus again? We do. Because it's not for mom, it's for baby. It protects baby. And is it the tetanus that it helps? It's actually the pertussis. The pertussis that helps, right? So that's what doesn't matter if I was pregnant 2 years ago and I was pregnant last year and I had it. Well, you're getting it again today because it's for baby's protection for pertussis. All right, so let's go through this first prenatal visit and all the things that we look at this first prenatal visit. Okay, in the United States and other developed countries, pregnant women have about 7 to 11 prenatal visits in a regular pregnancy that is going well. Of course, if there are any complications, then those prenatal visits are going to increase. Their first OB appointment is typically around 10 to 12 weeks, so we're again towards the end of that first trimester. And oftentimes, this first appointment is in a group setting. It's called Center for Pregnancy. And it's really this group-based model for prenatal care. What we think of it as like standard prenatal care, where they go through this really good class on childbirth and what they can expect throughout their pregnancy. So instead of seeing a midwife or a doctor initially, they'll start with this group-centered pregnancy. Now, once they're finished with that group counseling, then they get sent for other things like lab and ultrasound as individual basis. And they even do this Center for Pregnancy in the military. The primary reason why they started doing this was they feel like and especially new parents are able to talk to other men and women that had children, that they can learn something from the situation that other people have been in. Another focus for the initial evaluation, we're going to look at, again, patient's medical history. They're going to do torch screening. There's no labs specifically that they're going to send everybody for, but they're going to screen these patients for their risk factors for torch. Okay? We also want to identify how far along is this pregnancy, and they're going to do a physical exam. That physical exam, if they need, we'll include a PAP exam or a pelvic exam. Again, once they're done with that initial group counseling, then they're going to move them to more of a private room, and they're going to ask them these more sensitive questions, more private questions. Other things they ask about is substance abuse, any evidence or any history of depression, taking any medications for depression, any intimate partner violence, either now or previously, and they're going to give referrals for depression, referral for substance abuse or intimate partner violence. That's ongoing. The thing for depression is depression typically doesn't get better throughout the pregnancy. It typically gets worse. And so they're going to address that on every single visit that these patients have. Depending on the location of the hospital, will depend on what services are available and where those people are going to go for specific things throughout their pregnancy. Okay, so we'll talk to them about the scope of care that's available in the hospital where they're at, and where they should go if they have a medical emergency or an OB emergency, either early on or later on in the pregnancy. And they'll also talk about what are some specific reasons that you should seek medical care. Okay, if you're having vaginal bleeding, if you're having abdominal pain, if you're having persistent nausea and vomiting, those are the reasons to seek medical care. Okay? And whether this is the first pregnancy or the fifth pregnancy, they're going to talk to them about the expected course of the pregnancy, okay? When the follow-up visit should be, and what they can expect at those specific visits. They're going to talk about exercise, diet modifications, what labs that need to be done, okay? And past medical history, past family history, and they'll identify if these patients are at risk for genetic disorders and if they need additional genetic screening. Okay. They often talk about, again, perinatal and but postpartum depression as well, and what signs to look for. So ideally, this is done with both of the partners at this visit. Intimate partner violence is really prevalent in pregnant women. So they're going to ask at every single visit, are you concerned at home? Is someone hurting you at home? They're going to look for signs of abuse. And remember, a lot of times the signs of abuse are going to be on the trunk area, upper arms, upper legs, areas that they can hide. So they're going to look for that. They're going to try to identify, is the other partner taking over the conversation? Is there anything in this conversation or in this counseling that indicates that there's some sort of abuse going on at home? If there's ongoing substance abuse, okay, they're going to provide medication-assisted treatment. Usually that's with methadone or buprenorphine, and that is preferred over allowing mom to withdraw on her own, because if mom withdraws on her own, there's much higher rates of pregnancy complications and much higher rates of relapsing. So they're going to use medication-assisted treatment, and I would know that. Reproductive history is really important. Okay? Not only when we talk about pregnant women, but when you're consulting GYN for somebody, they'll always want to know what their reproductive history. So you've got to know how to report this reproductive history in these patients. Usually we use the mnemonic GTPAL, okay, GTPAL. And what it stands for is G is gonna be the number of pregnancies, number of pregnancies. So if we say G2, that'd be 2 pregnancies. Okay, it doesn't tell us how many people, it just tells us 2 pregnancies. Now, where the confusion often comes in is the TPA, okay, that is all your parity. Okay, so whether it's a term pregnancy, a preterm pregnancy, or an abortus. Okay, so TPA is term, preterm, and abortus. And then L is your number of living children. And the L is where we capture these multi-gestational pregnancies and multi-gestational deliveries. Okay, does anybody know where this picture's from? Nobody? You know, you just don't want to say. Big People, Little World. Oh, I love that show so much. It's not on anymore because they're fighting too much. But so she's a full-grown person, and she married a not full-grown person. Full-grown. And what do they call it? Chondroplasia. So a dwarfism. And so she actually had, and she's pregnant now, but she has these 2 babies that are also chondroplastic. And then the 3rd baby that she ultimately delivers is also chondroplastic, which is kind of interesting. That's unusual. But if we look at her status now, I told you she's pregnant, she's got 2 babies there. Okay, her G status would be 3. She has 2 babies and she's currently pregnant. Okay, so that's her G status. If I tell you that both of those babies were term deliveries, okay, so we start with our P, the first P, after that P is your term delivery, so it'd be 2. And I tell you that none were preterm, that would be 0. None were abortus, that would be 0. And she has 2 living kids. Okay, that's your 2 living. So your G3 tells you the fact that she is currently pregnant. If I had G3P2003, is she currently pregnant? No, because she has G3 and P3. Okay, the last one, the L3. Okay. So G is your number of pregnancies, including the current pregnancies, and then your P is broken out to T, P, A, and then L is the living children. All right, so let's try it. All right, you got a 30-year-old female. She's 25 weeks pregnant with twins. She has 5 living children. 4 of the 5 children were born at 39 weeks gestation, and 1 child was born at 27 weeks. 2 years ago, she had a miscarriage at 10 weeks. Go big or go home, right? Do all of the things on this one. What is your GTPAL status? Okay, so let's start with total pregnancies. 7. Okay, total pregnancies is 7 because she has 5 children. Okay, she's currently pregnant, but she also had a miscarriage. Okay, so that's 7 total. How many living? All the way to the end. So let's start from the beginning. So 5 living. It says she has 5 living children. All right, so part of your GTPL is done. So you got to figure out the T, P, and A part. So how many term? 4 term. How many preterm? 1, 27 weeks. And how many aborts? 1. Okay, so we have then G7, P, 4, okay, 1, 1, 5. See how easy that is? You'll see that. Not this, but you'll see one again. You'll see one again. So make sure you kind of go through how to work this out. Make sure you understand twins or not twins, triplets, quads, it doesn't matter. You're going to see that in the living part. Okay, so if it says you delivered twins, that's gonna be in your living part. All right. Other things that we have to know about reproductive history, which gives us just kind of an overall idea of what to expect in this pregnancy. You want to know when was the last delivery, how many prior deliveries, what was the age of the delivery, okay? Was it vaginal, was it C-section, how did the baby do, what was the weight of the infant, was there any complications during the pregnancy? Any history of recurrent miscarriages, especially when I talk about like second trimester recurrent miscarriages. Remember we talked about complications or things that can cause recurrent miscarriages. People have recurrent multiple colposcopies or LEEP procedures or CKC procedures. And for those people that have these recurrent miscarriages, they may end up with a cerclage. You know, they feel like it's from cervical insufficiency or incompetence, and they'll sew the cervix closed to keep the baby in there. Again, any history of prior gestational diabetes, meaning they don't necessarily have diabetes outside of pregnancy, but if they have history of prior gestational diabetes, they're much more likely to have gestational diabetes again. And then eclampsia, any history of preeclampsia. For these patients, if they do have a history of preeclampsia, then the current recommendation is to put them on 81 milligrams of aspirin a day starting at 12 weeks. And it's been shown to reduce their chance of miscarriage or preeclampsia in the future. So starting at 12 weeks, those patients will go on aspirin. There's a lot of labs that need to be done. First of all, we've got to confirm the patient is pregnant. You will run into situations where patients come in and they swear that they're pregnant. I know I'm pregnant because I have breast tenderness, and I have this, and I have that, and I'm nauseous, and this is exactly how I felt in my prior pregnancy, so I know I'm pregnant. You don't even have to test me because I just know I'm pregnant. And then, oh, well, they're not pregnant. You only have to send a patient once to ultrasound saying, you know, first trimester vaginal bleeding, please evaluate further for the ultrasound tech to say, you do know this patient's not pregnant, right? No, actually I didn't, because I went for like 3 seconds. So very early on in my career, I never made the mistake again, right? But these patients will convince you that they're pregnant. So just get a pregnancy test. We got to confirm that. We got to figure out what their ABO-RH status is. Are they RH positive or RH negative? They have something called antibody screen, and they're just looking for atypical antibodies like, I don't know, anti-Duffy or anti-M. CBC, they want to know if these patients are anemic from the beginning of pregnancy because it'll change their prenatal vitamins and the amount of iron that they're given in their prenatal vitamins. Of course, torch infection screening. This is going to be about history. You know, there's not really any specific labs for all the torch infections. They'll do a urine and a urine culture from the very beginning. They'll check gonorrhea, chlamydia, syphilis, HIV is typically recommended. They'll do rubella screening as well. And then again, if they don't have a recent pap screening, they'll do that, send that off, and genetic screening as needed. Unless everybody gets the baseline genetic screening, and then there's other genetic screening that can be done as well. In pregnancy, we can expect HCG levels to double about every 2.2 days. It rises really fast at the beginning. If you remember that there's really not a big placenta at the beginning, and so HCG is coming from the embryo. The embryo keeps the corpus luteum around. The corpus luteum is kicking out progesterone to support that developing embryo. So that corpus luteum is essentially acting like a tiny placenta, and it's getting the HCG from the embryo. At the end of that first trimester, that's when the placenta is formed, and so we don't need HCG as much, and so we'll have a little bit of a decline in our HCG levels, and then they'll plateau for the remainder of the pregnancy. Urine, we have urine qualitative tests that can be done, and that just tells you what? Positive or negative, pregnant or not pregnant. Once we identify someone's pregnant, we really want to get a urine or a blood quantitative test. We want to know really what their level is, and that level is really important, especially if someone ultimately comes in, they have vaginal bleeding, or having any complication with her. We want to follow those levels to identify, is there evidence that this patient is actually miscarrying because their levels are going down? Or are they in fact doubling every couple of days like we see? Sometimes like in an ectopic pregnancy, you won't have quite that doubling, it'll increase a little bit. And if this person comes in with vaginal bleeding, abdominal pain, that might be your indication that there's concern with ectopic pregnancy. There are occasions where you can have false positive pregnancy tests. Ones that I've seen are people undergoing assisted reproductive technology or treatment, and they're getting HCG shots. Well, HCG shots are going to increase your HCG levels even though they're not pregnant. That's from exogenous HCG. You can have a really early pregnancy loss where they're still having a positive pregnancy test, but there's no intrauterine pregnancy because they've already lost the baby. And then in men, if they have a positive pregnancy test, what's that mean? Testicular cancer. Was that on test today?
Yes.
Yeah. I tell you my story about, we were in the field and we were doing all sorts of crazy things. And one guy, he said, we were talking about putting in catheters. He's like, you can put a catheter in me. I'm like, okay, I guess we will then. So he took his knife and he bit down, he put a catheter in him. And that guy says, I said, oh man, we gotta do these pregnancy tests. He's like, yo, I'll just pee on the stick. So he peed on the stick and it was positive. And we're like in the middle of, a 30-day field problem. And I'm just like, oh man, that's so bad. And so we sent the guy back and he did get tested for cancer. So I was kind of joking around with y'all. Another thing we're going to do at that first pregnancy or that first visit, they got to identify how far along this pregnancy is, the gestational age. Okay? And that is usually can be calculated from the first day of the last menstrual period, or you can do a little math using the Natal rule. One of the nice things that I like in phase 2 is I got this pregnancy wheel. And this pregnancy wheel on the inside has the last menstrual period, 365 days. And then you line this, so if you line it up with the data of the last menstrual period, then you come up to this other area, or I guess you guys can't see that. You come up to another dark black line and it'll say EDD, estimated date of delivery. So you just kind of line up these two wheels and it'll tell you what the estimated date of delivery is. What's really funny about this, anybody pick out what's funny about this OB wheel? Tricycling. It's made by the darn contraceptive people. Yeah. So the other thing we can do is we can just do Natal's rule. So a lot of times they'll start with the first day of the last menstrual period. If you have the OB wheel, that's really nice. If you don't do Natal's wheel, we still need the first day of the last menstrual period. And then you subtract 3 months, add 7 days, and that gives you your estimated date of delivery. You may also see the estimated date of confinement. But they stopped using confinement because it was more of a jail sentence for these babies to be in non-belly for 9 months. Like, I don't know, that's what they said. So how do we do this? So if the last menstrual period is 16 January 2021, then you subtract 3 months from that, January, December, November, October. Okay, add 7 days. We started on the 16th, we had 7 days, so that's 23. So 23 October 2021. What gets confusing to people is if their last menstrual period was like November, December, October timeframe. They forget to add a year forward. So don't forget when you're doing this on the exam to add a year forward. And yes, I do have a little note here at the bottom. You can't also add 9 months and add 7 days. But here's the thing, that's not Natal's rule. Natal's rule says subtract 3 months and add 7 days. Okay, that's how it goes. Right, but really the best way to identify the gestational age is going to be with ultrasound. Okay, and that's done somewhere near that first, between 10 and 12 weeks. Ultrasound is most accurate if it is done in the first trimester. And they do it, they identify how far along the pregnancy is by measuring the crown to rump line. So just like it sounds, they're going from the buttocks to the top of the head, and the radiologist will measure that. They'll put the calculations in a little system, and they'll spit out a reading that says that this person is this many weeks with this many days along. Again, so ideally, we'll do this in this first trimester, and the reason is because if we wait till the second and third trimester, we have a lot of other confounders, right? If mom gains a bunch of weight in the first and early second trimester, then that's going to impact the baby. Mom loses a bunch of weight. If mom smokes, if mom's doing drugs, right? Maybe they didn't do drugs at first, but now they're doing. So all of that impacts the fetus, and so you won't have as accurate in that second and third trimester. What they will do is they will look at the last menstrual period, and they'll look at the ultrasound. And if there is a discrepancy between the dating of the last menstrual period and the ultrasound, okay, depending on how many days the discrepancy is, they will have to change what the estimated date of delivery is. Okay? So a patient comes in, they're 10 weeks along, based on the last menstrual period, we're going to give them an estimated date of delivery. All right, you can expect to deliver around this time. Then the ultrasound is done, and the ultrasound says, oh no, they're not. They're either further along or they're not as far along. Okay, so in that, if they're less than 9 weeks and there's more than a 5-day difference between the last menstrual period calculation for EDD and the ultrasound calculation for EDD, we have to adjust the EDD based on the ultrasound, not the last menstrual period. Okay, based on the ultrasound. Okay. 9 to less than 16 weeks, if there's a 7-day difference, then we have to adjust the EDD based on the ultrasound. This goes all the way through pregnancy, but really we just get more concerned about in the early portion of pregnancy for our purposes. Genetic testing, we talked about some genetic testing that is done. Another genetic testing that is done for all pregnant women who have prenatal care before 20 weeks is Down syndrome. You're going to be screened for Down syndrome. And that's because that's the most common aneuploidy and causes about 1/2 of all fetal chromosomal abnormalities. Okay, in the first trimester, this is done typically via ultrasound. Okay. And then in the second trimester, and that's usually for trisomy 21. In the second trimester, they're looking for 21, trisomy 13, and trisomy 18, which is Edwards. Okay. So they can do that testing both in second, and they will do it both in first and second trimester. For that first trimester, it is done with the ultrasound. So that same ultrasound that they're using to establish the date of delivery or the EDD is that same ultrasound they're going to use to look for evidence that this patient may, or that this baby may have Down syndrome. Remember that this is only a screening tool. Okay? And what they're looking for on that ultrasound is they're looking behind the baby's neck, and they're looking for leukotranslucency. They're looking for a thickened area that will indicate that this baby, again, may have. Other things they're looking for, though, is they're looking at the nasal bone on the baby. And so if they see that leukotranslucency, but then they go and they look and they find the nasal bone, they kind of cross each other out. So yes, you have thickened leukotranslucency, but the baby has a nasal bone, so there's really no discrete evidence that they have Down syndrome. So if that's the case, they'll add other things. They'll add something like a Papa-A or total HCG. Okay? And that helps, and then again, hone down, because there's still screening tools, but hey, we're more apt with this Papa-A or HCG to, yes, be leaning towards that this baby may have Down syndrome, or no. So depending on what the levels are for the Papa-A and HCG. So this is what that leukotranslucency looks like. You'll see one picture that says normal, and then you'll see another one that says abnormal, and that's that area they're looking at behind the neck. They're looking for that thickened area for leukotranslucency. And then here is the nasal bone that they're looking for. So all of that is done in that first trimester ultrasound. So nasal bone decreased risk, and kind of will, even this baby has a thickened nucleotranslucency, but a decreased but a negative bone present, so we're not really sure. We ought to add some additional labs to that. There are other reasons that we do first trimester ultrasounds. Okay, if someone has, we want, of course, we're going to confirm that the pregnancy itself is in the uterus. If someone has abnormal vaginal bleeding or vaginal bleeding, so vaginal bleeding in the first trimester is very, very common. But if someone's having bleeding in the first trimester, they're always encouraged to seek medical care to make sure that there's nothing else going on. So we're going to use the HCG level, we're going to use an ultrasound to help us identify if there's any other reason for that to have vaginal bleeding, any indication that they're having a miscarriage. Okay, of course, we're going to use this to estimate gestational age. And then even things like you want to make sure that the baby has cardiac activity. You want to make sure that there's no evidence of something called gestational trophoblastic disease. We'll talk specifically about gestational trophoblastic disease, but essentially it's a where the trophoblastic cells just grow out of control instead of having a viable pregnancy. So I would make sure that you mark this slide and understand those areas that I highlighted on reasons to have first trimester, all reasons for first trimester ultrasound. If that carrier screening was not done prior to pregnancy, it can be done in that first trimester. It can be done by a blood sample, it can be done by a cheek sample, and that's sent off. Again, targeted screening is done for those things that we talked about, Tay-Sachs, sickle cell. And then there's something called expanded carrier screening. This gives, it's for about 100 plus, I think it's about 110 other genetic disorders that could be possible for these patients in this pregnancy. And I will be honest, I don't know if anybody knows, I'm not sure if the military does expanded screening. I know on the outside you can pay to get this expanded screening done, because a lot of health insurance companies don't cover it. But it's done by outside labs, so I'm not sure if we get this offered in the military. I know the targeted screening is on it. And they're going to look at that ultrasound for neural tube defect. So they do the crown and lump, they look up here in the neck, they go down to the spine, and they're looking for all of this, and then they can do genetic testing for neural tube defects as well. Neural tube defects, the neural tube closes about 28 to 32 days after pregnancy. And so if there is some sort of defect, it means there's some sort of opening in the spine, something didn't close. And it can be from the lower spine all the way up to the cervical spine, and even in the posterior head area. Okay, the first trimester screening is done with that ultrasound, and then the second trimester we'll use something like a triple screen and then ultimately a quad screen. And there's specific tests on there that look for the maternal serum alpha-fetoprotein level. And if that is elevated, that's concerning that this baby has a neural tube defect. So what we want to talk to our patients about is folic acid supplementation, which I've already mentioned. And then I'm going to avoid hyperthermia, avoid saunas, avoid hot tubs. Hyperthermia increases the risk of anencephaly and neural tube defects. Medications like valproic acid that is used for seizures, those medications can increase the not bioavailability. What's the word? Where you like synthesize it really fast. Metabolism. That's it. That's the word. It's hard. Words are hard. Words are hard. Postmenopausal, they're so hard. Metabolism. It increases the metabolism of folic acid, so those people need to have a lot more folic acid during pregnancy. Okay. Neural tube defects could also be, based on ethnicity. Certain ethnicities have an increased risk. And then, of course, if there's a family history. Neural tube defects are seen more often in female than male genders. And again, for screening, we do that first trimester with the ultrasound and the second trimester with the triple screen. Okay, we're going to screen for bacteriuria, so bacteria in the urine, and that is done with that basic urine and urine culture. If you read literature prior to 2023, anybody that had bacteriuria had to get treated. Okay? Cross that out of your mind if you knew that, because that is not the case nowadays. As of September of 2023, we still screen, okay, but only if the colony count is greater than 100,000 do we treat. No, we're talking about asymptomatic. These patients are otherwise asymptomatic, meaning they have no urinary tract symptoms, no fever, no flank pain, nothing. But we do this urine comes back okay, but the culture is sent and the culture comes back greater than 100,000, then we treat. Nitrofurantoin is fine, amoxicillin is fine, and I know you guys have been told nitrofurantoin can't be used in first trimester pregnancy. That's not true. Not true. And then you probably don't remember that you were told that, so don't worry. But it's not true. We can use it in pregnancy. Amoxicillin can also be used. Cephalexin can be used. Actually, cephalexin has really had a rebirth in the realm of UTIs. We use that a little bit. Okay. Here's the other issue, is that about 30%, if you were to repeat their urine culture, about 30% of those patients are going to have persistent bacteriuria. So the recommendation is don't repeat it unless they're symptomatic. So every visit they come in, you ask them about urinary symptoms. If they have no urinary signs and symptoms, we don't need to repeat their urine culture. Okay? If they do have symptoms, and they ultimately have a UTI and they have symptoms of pyelo, you guys should remember pyelo, fever, flank pain, probably tachycardia, nausea. And those patients need admitted to the hospital. Pregnant patients with pyelo is bad. They usually get admitted to the hospital for IV antibiotics to make sure they're pill tolerant, and then after a day or two of IV antibiotics, they start to know. And even nowadays, if they don't give them IV, they'll still admit them and give them orals if they can tolerate orals. Another check on learning. Estimated date of delivery for a person's last menstrual period was on 10 November 2021. Subtract 3, add 7, what we got? August 17, 2022. Oh, we gotta add a year for August 17. All right, another one, 26-year-old female comes in. She is 26 weeks pregnant. She had a miscarriage at 10 weeks, 5 years ago. And she had a 3-year-old who was born at 39 weeks. What is her GTPAL? So how many total pregnancies? 3 total pregnancies. How many does she have living? 1. Okay, well then you only brings it down to 2 answers. All right, so what do we have? So she had a miscarriage. So that's going to be the year 1, and then 39 weeks. Is that good? That term? Okay. So we have then G3, P1, 0, 1, 1. G3, P1, 0, 1, 1. Let's hope that it's that easy on the test, right? All right, let's take a break and then we'll finish up. Low mercury containing fish. So we've got a couple pictures here, but shrimp, pollock, tilapia, catfish, tuna fish in a can, but not albacore tuna fish, because albacore tuna fish is high mercury. So make sure you understand which fish is good and which fish is not good. King mackerel, which we get down a quart a here, swordfish, orange roughy, albacore tuna, those are not recommended. It's not recommended to go on a camping trip and catch all the fish in the world and eat those fish for dinner while you're pregnant. That's not recommended. We don't know what the mercury content is in those fish, so you have to be really careful. And then what about sushi? People say, yeah, well, if it's cooked. Well, technically, you shouldn't have sushi at all in pregnancy. But if it's cooked, I mean, I suppose you could get away with it, but it's not recommended. It's really not recommended. So we tell our patients no. Just tell them no. You don't have to go say, look, I'm just telling you what they say, you can do what you want. Just telling you what they say. And then other foods to think about, dairy, okay? We gotta be careful with unpasteurized dairy products and soft cheeses, okay? Because of the likelihood of increase of listeria. Hot dogs and lunch meats. We don't want to go to the local deli and get those lunch meats. Okay? We don't want to eat raw hot dogs because, again, of listeria. We want to avoid raw eggs. This is not the time to do protein shakes with those raw eggs because that can increase the risk of salmonella. Again, we talked about undercooked meats already. The best thing is to put those meats in the freezer, and then that reduces chance of toxo, and then cook them. You don't need no temperature, it's about 159, 160 degrees. We don't want smoked or refrigerated seafood either. Okay, artificial sweeteners. Okay, they say generally safe in pregnancy, but we do not want to use saccharin. Saccharin is in the little pink packet. Like you can do the yellow packet, but not the pink packet, because that does cross a placenta and cause issues. And herbal supplements. People like to take a lot of herbal supplements, but herbal supplements, remember, herbal supplements are not FDA approved, right? And so they like to do herbal teas because they're nauseous and all these things, but the problem is you can get toxic on those herbal supplements and herbal teas. So it's okay in moderation, but they shouldn't be doing these herbal supplements or herbal teas every single day. Again, even if we have iodine supplements, that can cause goiters in the babies, so we have to be careful with that. We know we have to wash all fruits and vegetables, whether they're homegrown or they're purchased from the store, all of them should be washed. And probably even outside of pregnancy, we should wash them, I think most people do. And again, herbal teas. Herbal teas can cause premature contractions. Same thing with herbal supplements, we gotta be really careful. Raspberry leaf tea actually used to be used to induce labor, so we gotta be careful with those things. We talked about neural tube defects with hyperthermia. Avoid all saunas and hot tubs throughout the entire pregnancy, not just at the beginning of pregnancy. Sometimes we think about because the neural tube closes at 28 days, then after that they can go in the hot tub and sauna, when it's really not recommended for them to do any hot tub or sauna throughout the pregnancy. Okay, caffeine during pregnancy is controversial. A big take of caffeine greater than 500 or so, is thought to have an increased risk of miscarriage. And so in moderation, maybe a half of a large Starbucks coffee is okay. But usually we try to keep it to less than 300 milligrams a day of coffee. Not of caffeine, not just coffee, but caffeine. Tobacco is terrible. It doesn't matter how it's done, cigarettes or vaping, dipping, even secondary exposure. All of these are not just the nicotine, but all the metals and the toxins that are in these products are dangerous for mom and also dangerous for baby. And secondhand smoke has been linked to low birth rates. And the response on the baby often tends to be kind of dose depends. So how many cigarettes is mom smoking a day, or is mom exposed to a day? But we do have increased risk in low birth weights and then fetal growth restriction as well. Other things that can happen, placenta previa has been linked to smoking, miscarriage plus placental abruption, where the placenta will tear away from the lining of the uterus, or from the inside of the uterus. Sudden infant death syndrome has been linked to smoking as well. And then not for mom, but babies, parents that smoke have an increased risk as they become older, asthma and obesity. There's no safe amount of alcohol in pregnancy, regardless of what your grandmother says. Maybe not your grandmother, because your grandmothers are my age, but my grandmother said, you gotta drink a glass of wine in pregnancy. It helps, once a week or so you should have your glass of wine. Well, that is no longer recommended. Probably was not recommended then either, but they still did, right? So alcohol is really one of the leading causes of preventable developmental disabilities worldwide. Babies that are exposed to alcohol in utero, they have a lot of abnormal physical findings that you can see, but developmental delays are a big portion of that as well. Increased risk of heart issues, kidney issues, lung issues, ear defects. They can be born with omphalocele. Remember what omphalocele is? Well, abdominal organs are protruding outside of the skin. They have that. And so this baby here, that's a baby fetal alcohol syndrome baby. That's a classic presentation. Low set ears, they don't have a philtron. Their eyes are kind of out a little bit. This is also a classic presentation. So make sure you understand these signs and symptoms associated with alcohol. Because a lot of times these mothers are not going to admit to drinking in pregnancy. What's going to happen is they're going to deliver a baby that has these kind of physical exam abnormalities, and then you're going to retrospectively say, aha, I see what happened in drinking in pregnancy. And there's a lot of medications that these women cannot take in pregnancy. We don't need to memorize all those medications. A couple of things I would memorize. High dose aspirin, no, but that low dose aspirin, less than 100 milligrams, seems to be okay. And it's really important for us to know because, again, we use that in patients for reduced risk of preeclampsia. Okay? Acne medication like Accutane or isoretinoin are contraindicated in pregnancy. And I remember as primary care, I prescribed Accutane all the time, but you had to have a documented pregnancy test first before you can prescribe it. Tetracyclines and sulfonamide drugs are not recommended in pregnancy, or at least not late in pregnancy. Coumadin is not recommended in pregnancy, which will be important when we talk about people with DVTs and PEs, how we treat them. We do not treat them with Coumadin. So just kind of, you don't need to memorize that entire blue chart. I think the rest of these you probably already learned. So isoretinoin in pregnancy, we've got a couple of developmental disorders, but ear disorders as well. This one has one ear. This girl only has one ear. The other ear was not there because she not took isoretinoin in pregnancy. Weight gain during pregnancy is going to be based on the pre-pregnancy BMI. Pre-pregnancy BMI. Okay. So in the first trimester, 3 to 6 pounds weight gain is typically pretty normal. After 20 weeks, we think about a pound a week is pretty normal for the normal BMI person. 25 to 35 pounds of weight gain for a person with normal BMI, 18 to 24.9. So we want to make sure that you understand that. Weight gain, when we think about weight gain, we always think about must be the mom eating a lot late night, which does happen, right? So they do have cravings, but weight gain is not just mom eating, it's mom eating to support the baby. The baby itself is, by the second trimester, early first trimester, the baby is 7 to 8 pounds. That adds weight on fat stores to support the baby, 6 to 8 pounds. There's an increase in circulating blood volume of 3 to 4 pounds throughout the pregnancy. Increase in fluid weight of 2 to 3 pounds. Amniotic fluid is a couple of pounds, maybe more. The breasts get up to 3 pounds. So there's a lot of that goes into this weight gain other than mom is eating pickles and ice cream at 2 o'clock in the morning, right? So you want to think about that when we talk to these patients about this weight gain and weight gain. Even a placenta, 1.5 pounds. Auto and air travel, pregnant people and non-pregnant people should wear their seatbelt. Their legs should not be disabled. When they wear their seatbelt, the more gravid the uterus becomes, they want to put that the lap portion underneath the gravid uterus. So again, you're talking more in that late or that mid-second trimester when they'll start to have to adjust where the that portion of the seatbelt rise, so underneath the gravity uterus. And then the harness itself, typically between the breasts, is what's recommended. And I think there are nowadays, you can buy like seatbelt extensions that help a lot in pregnancy. And so it reduces the risk. You don't want it overlying the gravity uterus. That's kind of the idea of this, because if they get even a little fender bender and you have that pressure on the abdomen, that can result in a rupture of the placenta. Both the American Academy of Pediatrics and American College of Gynecology recommend that moms do not travel after 36 weeks by air. So safe before 36 weeks, but after 36 weeks it is not recommended. If anybody's going to be traveling internationally, we want to talk to our patients about what happens if they go into labor while they're traveling abroad or on vacation somewhere. Do they know the nearest place to go? What happens if they have any sort of pregnancy complications? And then we want to talk to them about potential risk for bacteria in the affected area, Zika virus as well. Exercise is good. We want to tell our patients to keep exercising fairly regularly. We do want them to avoid being on their back or being supine for very long, because that's going to compress the vasculature, the vena cava. We also want to avoid extreme temperature periods of time, no scuba diving, because that increases the risk of fetal decompression syndrome. Okay. But in general, no extreme cold, no extreme hot. You can exercise normally. Don't lay on your back very long, but there's people that are exercise up until almost the day before they're going to labor, and that's okay. We probably don't want to have to do marathons the day before labor, but it used to be, and I don't know if they do it anymore, but if mom was having a prolonged labor, what do they get up and do? Walk the halls, walk the halls, walk the halls to get that baby to descend down. Sexual activity during pregnancy is typically not harmful. There's really no association between preterm delivery or labor onset and the frequency of intercourse. However, it should be avoided after 28 weeks if there's risk for miscarriage, so someone has a prior history of miscarriage, if they have a known placenta previa, okay, or history of preterm labor. Okay, so avoided after 28 weeks for those things: miscarriage, placenta previa, preterm labor. Are the main things I want you to know. Okay? And you need to know 28 weeks. Did y'all know that dental exam was part of pregnancy screening or pregnancy evaluation? Yes, I did not know that. But good dental hygiene is encouraged all throughout pregnancy, because there is an increased risk of periodontal disease in pregnancy. And periodontal disease is actually related to can cause preterm labor. Okay. Oftentimes this is due to increased estrogen with increased circulating bacteria. Probably a little bit to do with what mom might be eating during the pregnancy as well. Maybe not eating quite as healthy as they normally would, but due to increased vascularity in pregnancy from the increased estrogen. So these patients can get dental treatment. They can get their dental x-rays. Those are not contraindicated in pregnancy. We just want to talk to them about good dental hygiene during pregnancy. Radiation. Most x-rays are not an issue. Most of the time they'll actually just shield the abdomen for x-rays, for plain x-rays, and they're associated with low dose radiation. So if you have a concern about mom, you should not avoid doing any radiology study if it's causing detriment to mom, even a CT. But most x-rays are okay. MRIs, they don't utilize radiation, so they're typically safe in pregnancy. We have a pregnant patient comes in, they have right low quadrant pain, we don't know if it's appendicitis. Typically they'll do an ultrasound, an MRI, and then if they need to, they'll do the CT. The CT scans nowadays are a lot less radiation than they were even 10 years ago. Okay, so we need to do a CT scan, we do CT scans. We talk about CT scans for people who have pulmonary embolism. VQ scans actually have more radiation nowadays than CT scans. But If we can avoid the CT scan, we will. We certainly do not withhold a CT scan for any life-altering, life-saving events. Work. Okay, I know it's oftentimes inconceivable that we can work and be pregnant, but you can. Okay? And I say that in jest, but you will have a lot of patients immediately when they find out they're pregnant that are going to come to you because they're not going to see OBGYN for 10 to 12 weeks. So they're coming to you for their initial pregnancy profile, right? And they're going to say, well, I can't work. You can, but if you work in the motor pool next to the fuel and generator mechanic, then maybe we should alter that. But you can still do basic work, even military work. You can do buck marches, you can do those kinds of things. Most of the time in your clinics, you'll have pre-printed pregnancy forms that you just have to sign and give it to them. Okay, so and those are given to the clinics from OBGYNs. We want to avoid, especially later on in pregnancy, undue physical strain, lifting heavy objects. A lot of times these guys later in pregnancy will have 8-hour days, maybe down to 4-hour days. Especially if there's a history of pregnancy complication, then we want to make sure that we document that appropriately and give these patients, if they need more than just that general pregnancy profile, then we want to make sure that we give that to them. But the biggest thing that we come up with in the military is the environmental stressors. Make sure you understand where they're working and what they're exposed to, and see if you have to move them from that to an administrative job for the remaining portion of the pregnancy. Domestic violence, we know that's now called intimate partner violence. Again, just the state of being pregnant increase in risk of intimate partner violence, and there's a lot of adverse outcomes associated with that. Preterm delivery, fetal growth restriction because of the stress that's placed on mom. Mom's probably not eating as well. That's going to put stress on the baby. Perinatal death, and then even maternal death as well. So we're going to screen for that at the very first visit, and they're going to screen for it every single visit afterwards, and then even at those postpartum visits, 6 weeks after delivery. It is recommended by all agencies that we do this screening. And there's a variety of ways that you can do this, but most of the time in the military, we'll use just a screening tool like we see here. We can print that off and use that. Again, all the intimate partner violence and then depression kind of go hand in hand. For these patients with intimate partner violence, or if they have a history of depression, we want to screen for that every single visit. And we want to make sure that if they need referrals, we give them referrals. If they have substance abuse problems, we want to give them referrals for that as well. Even talking about eating disorders during pregnancy. This is screened for every single visit. Okay, that's it. Thank you. Have a good weekend.